My name is David Anderson, and I'm the CSO for VBI Vaccines. I'd like to share with you an update based on our poster presentation at AACR on immunologic and tumor responses from Part B in our ongoing Phase 1/2A clinical study of VBI-1901, our cancer vaccine immunotherapeutic in recurrent glioblastoma patients. I'm joined today by Dr. Alan Waziri, who's a member of VBI's GBM and Immuno-Oncology Scientific and Clinical Advisory Board. He's also the CEO and co-founder of ICE Neurosystems and has a background and extensive training in as a neurosurgeon as well as in detailed immunological investigations of glioblastoma brain tumors. So Alan, thanks very much for joining us.
Many thanks, Dave. It's great to be here.
I do, before getting into these recent data, need to refer you to the press release that we issued this morning, June 22nd, 2020, for more details, and to the disclaimers regarding forward-looking statements and additional disclosures which are outlined here. So here on this slide, this really summarizes the overall study design. There were two parts. The first part focused on demonstrating safety, which we did. We identified the most immunogenic dose, and then the intent was to take the most immunogenic or optimal dose and have an extension phase, adding additional patients, so we could hopefully amplify any signals or trends that we saw in Part A. We initially used interferon gamma ELISpot assay to define vaccine responders versus non-responders. And as you can see here, we reported earlier this year encouraging correlation in the sense that tumor responses were only seen in the vaccine responders, and that translated to improvements in both median overall survival as well as 12-month OS rates. So that had us encouraged, but ultimately if you speak with the neuro-oncologists, they want a biomarker which would enable them to better identify patients most likely to benefit from treatment. And that's something that we've been working on in the background, and it's now highlighted here on this slide. Essentially, the CD4 to CD8 ratio is what has proven to identify quite nicely those that had a tumor response versus tumor progression. On the right-hand side, you can see the classic spider plot really showing the stable disease was associated with this biomarker, and for the first time, we're reporting a partial response. Let me just pause here and ask for your take on these data, Alan.
So I think what you were mentioning about heterogeneity and the fact that there's not going to be a magic bullet or a one-size-fits-all is really critically important here. The ability to target therapy to the patients that are most likely going to benefit from it, it would be a major advance in glioblastoma treatment. What's even more interesting is that the biomarker that is coming out of your data analysis is actually something that we've been watching in glioblastoma for decades. We're not really sure why this happens, but there's a subset of patients who have altered CD4 to CD8 ratios, and the fact that you can take this well-known phenomenon that can be very easily tested for in many clinical environments and use that as a kind of divining rod for who's going to benefit from the therapy, I think is extremely powerful.
Yeah, it's encouraging to hear. Now, as I've just mentioned, we saw our first partial response, and what's shown here is our series of MRI scans for this patient. With your benefit, let me ask you to just kind of walk us through what we're looking at here, Alan.
Sure. This is a pretty classic appearance of an MRI, a series of MRIs actually from a patient with recurrent glioblastoma. The primary resection cavity is located on the left side of the scan, which is the right side of the brain, the right temporal lobe, that area that's got the dark center and the kind of bright enhancing rind. And that's obviously stable, over the 9 months of scans. But more importantly is the region that is encircled by the red line. That's very classically seen in recurrent glioblastoma, where there's an area of enhancement or recurrent tumor outside of the zone of primary tumor. What's really interesting is that over the course of the 9 months of therapy, it's presumed the patient is only receiving vaccine. And not only are things stable around the primary resection cavity, but you're seeing an involution of the area that is the recurrent tumor, which is very interesting if the vaccine is truly the monotherapy here.
Great. So I think we certainly recognize that it's still relatively early in the clinical development of 1901, limited numbers of patients, but I think based on these data, this partial response, this newly identified biomarker, this certainly warrants exploring a randomized controlled registrational trial expected to begin sometime in 2021, which we're excited about. Let me just pause before thanking you, Alan, to see if you have any final thoughts.
No, I think, just wrapping everything together, the fact that you have a therapy that can be potentially targeted to a subset of patients based on a biomarker that's readily available in the majority of settings is extremely interesting in the glioblastoma field.
Thanks so much.